Hello?
Hello.
Hello, hi. Can you all hear me?
I can
Yeah,
hear
we
you.
can.
Yeah,
Yep.
sounds good. So I'll get off from my phone here. Good afternoon, everyone, or good morning, everyone. Today we have a series of the Distinguished Speaker Series, and today we have the pleasure of having Dr. Barnato, who's the John E. Wennberg Distinguished Professor and Director of Dartmouth Institute for Health Policy and Clinical Practice at the Geisel School of Medicine at Dartmouth. Her research focuses on understanding the causes and consequences of variation in end-of-life care intensive care unit and life-sustaining treatment use among seriously ill older adults using an array of scientific methods. So this is something which many of us can relate to as an ongoing problem in our clinical practice, which we go through every day in our practice. And it's something of very important, or very serious importance both to population health, clinical science, and policy. It's a work increasingly focuses on the interplay between organizational norms, provider-patient communication, and implicit cognition, and how these phenomena produce racial disparities in end-of-life treatment. Again, something which all of us have to deal with on a day-to-day basis. So uh, this it's a great pleasure for us to have you here on something which is an extremely important topic, and for our institution and population health in general. So thank you, Dr. Bernardo, for coming in and giving and agreeing to share your thoughts on this.
Well, thank you for that introduction and for inviting me to give this talk. I'm delighted to have the opportunity to share some of the work I've done over my career here. I'm going to share my screen now, and you all let me know if you're seeing the presentation mode or if you're seeing the slides.
Seeing the slides. Looks good.
Terrific. So the title of my talk is The Beauty of Triangulation, a 25-year quest to understand variation in end-of-life care. This work has been funded from the National Institutes of Health, American Cancer Society, multiple foundations, including Greenwall, Jewish Healthcare Foundation, the Winters Foundation, the Donahue Foundation. I've also received funding from the University of Pittsburgh and Dartmouth for my work. I have no financial conflicts of interest. So to start with, kind of what do I mean when I say triangulation? And so triangulation is an approach to sense making and validation of complex phenomena. It's this idea of you have to look at things from multiple different angles to try to make sense of what's happening. And there are different forms of triangulation. There's data triangulation, so you can get data from different sampling strategies. You can get investigator triangulation, in particular, people who have disciplinary backgrounds that are different to try to make sure that everybody is essentially seeing the same things versus not just through their own disciplinary lens. Similarly, different theoretical frameworks, methodologic triangulation, and then environmental triangulation, which is different locations and environments. And so what I've done throughout my career is, as you heard in the beginning, is I've used multiple different methods and a multidisciplinary collaborative lens to try to understand what I first saw when I was an intern and a medical student. So this is a photograph of me. You can see it's time-stamped July 2nd, 1994. This would have been in my first week of general surgery internship. And here I am presumably writing like those post-op orders to admit the patient from the operating room up to the floor. I'm clearly like triple tasking. I got that little pharmacopoeia. Do you guys remember that from the olden days? You put in your pocket. It was to help you write your prescriptions and get the doses right. I'm talking to somebody on the phone and I'm writing orders. I am, of course, as you can see, not operating because as an intern, you don't get to operate very much. You spend a lot of time doing administrative work. But what I did do, which was in a unique experience from my internship at the University of Colorado, is that three PGY2s quit during my internship because of moral distress. Two interns in my class became suicidal and were taken off service. This was back before duty hour changes. We were working 110 hours a week. And because of these changes in staffing, I spent 6 months of my 12 months of internship staffing the ICU, kind of doing a PGY2 job. And I saw a lot of people connected to life support without a clear plan or discussion about kind of what we were hoping for, and an increasing concern that the treatment might not achieve the goals that the patient might implicitly have of getting back to their prior state of health. And this led me, again, similarly, to have an experience of moral distress, and it led me onto a pathway of trying to study this phenomenon. I quit my general surgery residency after completing my internship, but while I was kind of searching for what I was going to do next, I moved home with my mother. I didn't have a plan. Um, I heard on the news, NPR, about this study. So CASE was actually one of the uh, I think University Hospital was one of the 5 centers in the study to understand prognoses and preferences for outcomes and risks of treatment. This was this 5-center study that looked at how people died in the United States who were admitted to the hospital with serious illness, and they identified a lot of quality problems, one of which was that there was not necessarily an alignment between what the doctors knew about the patient's preferences and what the patient's preferences were. And for those of you who are in the know, the support trial, which was funded by Robert Wood Johnson Foundation for bajillions of dollars, had an observational phase and then an intervention phase. And the intervention was an abject failure. It was where a nurse used Al Connor's very cool prognostic model to predict the likelihood that the patient was going to survive to hospital discharge. And she put that on the top of the chart to sort of let the attending physician know whether or not this patient was looking like they were going to make it out alive. And unsurprisingly, this risk communication or information communication did not change practice patterns and did not improve end-of-life care. So I heard about this study and I thought, oh my gosh, there are people. First of all, I'm not crazy for being distressed, at least, the kind of what's happening in the ICU these days. And there are people who are doing research and trying to make it better. So it led me on. I was like, okay, I can become a researcher. That's what I want to do. At around the same time, the Dartmouth Atlas started mapping variation in end of life intensity by region. And so I had had a lived experience. The support study, which you all were part of and Dartmouth was part of, kind of demonstrated kind of anecdotally from an observational perspective what's happening to patients admitted to hospitals. And then now there's this national study using Medicare claims data showing that there was this huge variation. These are hospital referral regions. Many of us are aware of these data. This whole idea to map healthcare delivery by small area variation was established by the professor namesake of my endowed chair, Jack Wennberg, along with Alan Gittleson, in a paper in Science in 1977, looking at the healthcare use in regions to look at these variations to suggest maybe things aren't so science-based after all. And in this case, aggregating the percent of deaths associated with intensive care admission among chronically ill Medicare beneficiaries. So you can see the dark red areas are areas that have high rates of ICU admission in the last 6 months of life among seriously ill patients, whereas those lighter kind of yellow colors are areas that are sort of lower treatment intensity. And this variation was sort of a mystery. Why is this happening? So this led me to, I ended up completing a residency in general preventive medicine and public health at the State Health Department. And then I went on to complete my healthcare delivery research fellowship and a Master of Science at Stanford under Alan Garber's leadership, who is now, as you all know, the president of Harvard and fighting the good fight against administrative overreach of federal grants to universities. And I published this paper, which was looking at the secular growth in healthcare utilization. There was this story about, we spend something like 25% of expenditures among Medicare beneficiaries in the last year of life. Or rather, this idea that it was sort of like a huge kind of waste of money. But that would imply that we were disproportionately investing in decedents' care versus survivors' care. And what I found was that it really turned out that the growth in intensive care use or life-sustaining treatment, it was happening equally among survivors and decedents. This is the ratio of expenditures in the dotted line across the top between 85 to 99 when I did my study, and then ICU admissions and hospitalizations. And so what looks on the face of it to us as clinicians is, oh my God, we're treating dying people more and more intensively, is simply that we're treating everybody more intensively, and the people who are dying are the ones that are upsetting us. So there's kind of cost growth and treatment intensity growth is happening among Medicare beneficiaries the same, regardless of whether they survive the hospitalization or die. Alan Garber introduced me to John Skinner at Dartmouth, and I started collaborating while I was at the University of Pittsburgh with the Dartmouth group. And one of the papers that I was privileged to write, they had done a national sample survey of Medicare beneficiaries, asking them, and it's a little bit hard to see, it's kind of small. I'm going to read out what the survey prompts were that they read. This is basically, I would be concerned that I would receive too little medical treatment if I were near the end of life. I would be concerned that I would receive too much medical treatment. So you see those top two are sort of like opposite ends of the same thing. If I would prefer to spend the last days in the hospital, you see very few people want that. I would I would want drugs that would make me feel worse all the time, but might prolong my life. I want drugs that would make me feel better, even if they might shorten my life. You see more people want that. I would want mechanical ventilation if it would extend my life by 1 month. Uh, or I would want it if it would extend my life for 1 week. What I've got here is I've got the respondents to this national survey categorized from the quintile 1 to quintile 5 of the treatment intensity in the area in which they live. So if we believed what's called the preference hypothesis, that the reason people get more intensive care in quintile 5 is because they want more intensive care, then we'd expect to see that the number of people who saying things like, I want to be mechanically ventilated, would increase in a stepwise function as you went from quintile 1 to quintile 2. But as you can see in those bottom two sections, there's no difference whether you live in a low intensity region or a high intensity region. About 20% of people would want mechanical ventilation to extend their life by a month, and about 11 to 12% would want it for a week. And so what you see here is that regional variation in end of life intensity. So like this was the thing that I had to reject first in this sort of like case that people make, which is all of this variation is just due to regional variation in preferences. This was a study that said, no, that's not the case. And so what I started looking at, and also the Dartmouth Atlas at this time started looking at, is sort of thinking about, okay, well, maybe region isn't the right measure of treatment practice patterns. Let's look at hospitals. And so I started using Pennsylvania hospital discharge data. I was at the University of Pittsburgh at the time, and basically mapped out every single hospital in the state of Pennsylvania. Every one of the dots here is a hospital, and the size of the dot is how many admissions. And the color of the dot actually corresponds with how the hospital compares to an average in the state of Pennsylvania, where kind of gray, that's sort of like the like pinkish to kind of gray is average. And then if you're red, you have a higher end of life treatment intensity, and green, you have a lower treatment intensity. And as you can see from this map, you see a big mix of places that are red, pink, and green, and gray. It does appear that there's some correlation with size, but not completely. There are many large hospitals that are in that kind of light pink or kind of a more of an average treatment intensity. And so I started focusing a lot on like, okay, well, what's happening in the hospitals? So this is a graph that shows hospital level end of life treatment intensity. And I have it, every circle is a hospital. Those are the standard deviations in the middle, a mixed measure of precision. And we looked at the treatment intensity at the hospital along the y-axis is if it's measured among people who, at the time of admission, they're at high risk of dying. And on the x-axis is if they, on Monday morning quarterbacking, were found to have died. This has been a key critique of a lot of the research done at the Dartmouth Atlas, is that they condition on decedents. And Peter Bach wrote a terrific article in JAMA in 2004 that said something like, the title was Resurrecting the Treatment Histories of Decedents, a Study Design That Should Be Laid to Rest. And he said that this case series method, where you take people who died and look back in time to see what happened to them, that's not how doctors operate. Doctors operate, I got this patient in front of me. I don't know whether they're going to live or die, but I have a sense of what their likelihood is of dying. And I'm going to, and just as I heard Dr. Sundaram say today, you have a conversation with the family if you think that they're very high risk of dying and that the treatment may be more burdensome and not be likely to achieve their goals. And so we make decisions to initiate treatments based on what we think their predicted probability of dying. And what I found is it turns out it doesn't matter how you measure it. At the hospital level, if you measure a hospital's intensity among people who died or people who are at high risk of dying, very similar rates, nice R squared here, even though only about there's a third overlap. Of the people at high risk of dying, the 95th percentile of predicted probability of dying, a third of them die in that hospitalization. So it's not because I'm measuring the same population. It's actually because hospitals have fingerprints. Hospitals have practice patterns. And any of you who've been from one hospital to another and arrived and thought, huh, this is different than the way I did it at my other hospital, know that this is true. And so, what we found, when you start trying to look at structural information, like, oh, well, what about bed size? Or in this case, Herfindahl-Hirschman index, which is the market competition. Do they have practices like an ICU long length of stay review committee? I started doing surveys of these hospitals to see if I could find policies, practices, and guidelines that could explain the variation that I was observing. And what I found is that only half of the variation that I was seeing at the hospital, if it could be explained by the hospital case mix, the structure and processes, that meant that a good half was unexplained. One of the areas that I started focusing on, and which we mentioned in my introduction, is around like, how is it that the social construct of race influences a hospital's treatment intensity? And one of the things that I found was that the fraction of Black patients at the hospital, as that increased, the treatment intensity increased, not just among Black patients, but among white patients. So all patients at the hospital. And so this led me to do some work trying to understand this concept, which has now become very familiar to us as health services researchers, about hospital segregation. So this is a nice graph showing the hospitals in the sample in Pennsylvania, which are ranked by the number of Black patients who are at high probability of dying. And the red line, the dotted line, is white admissions. And as you can see, once you get up to 29 hospitals that have the highest concentration of Black admissions, they're serving 80% of all Black people in Pennsylvania. Once you get up to 95, you have almost all Black patients. In other words, Black patients are concentrated in a handful of hospitals. And we know this because of residential segregation, right? So people of Black ancestry tend to live in communities together and access the hospitals that are nearest to them. And because we have such racially segregated communities in our country, and Pennsylvania is no different, the Black and white patients are seen at different types of hospitals. And so this is a nice graph from a paper that I wrote. These are two panels. What I want you to look at on the left-hand side is, in both instances, I've arrayed the hospitals according to their treatment intensity, basically their ICU use at the end of life. And on the left, I show what percent of the sample is in each decile. And so you can see, if just with your eyeball, if the white people are in the light-colored bars and the Black people are in the dark-colored bars, you can see that there are more white persons treated in those hospitals that have lower terminal ICU use. And there are more Black patients treated in the hospitals with higher end-of-life ICU use. If instead you look at the decedents using intensive care in each of those deciles of treatment intensity, if you go to a low treatment intensity hospital and you're a Black or white patient, you can see the error bars overlap. You're equally likely to get intensive care. And if you go all the way up to the highest intensity hospital, similarly, Blacks and whites are treated similarly. So really what this led me to advance a hypothesis on is, it's not about the person's race and differential treatment by the doctor once they're admitted to the hospital. It's that Black persons go to systematically different hospitals, and those hospitals have different practice patterns. So I've showed you so far that hospitals have different practice patterns. They appear to be robust to different ways of measuring, whether by decedents or high predicted probability of dying. And that this variation explains in part the higher use of end-of-life care among Black patients, not because they have preferences for more high-intensity end-of-life care, but because they happen to sort to hospitals that are greater treatment intensity. So I started trying to ask the question of, well, how am I going to figure out why are hospitals different? So I essentially started using this is where my triangulation really got up and going. I started using a method, and I sort of thought about it as combining observation of real patient care, so just following doctors around and taking notes about what they were doing and interviewing them. I called that in vivo. And then I paired that with simulated decision making, where I took the same doctors and I ran them through a simulation. On the right-hand side, this is an image from a UCLA Sim Center where I've got the patient and the wife are played by actors. The doctor is actually my research subject. He's the one whose back is to us. And then there's a nurse playing a Confederate in this. And you can see the vital signs are very concerning. I have the simulation so that when the doctor comes into the room, they see that the patient's vital signs will lead to probably a code if they don't intervene. And the patient, they've been given information about the patient, including a chart that says the patient is riddled with cancer. There's no information about the patient's code status or preferences in the chart, just that they have advanced cancer, they've been admitted from a nursing home, and that they're fixing to have a respiratory arrest based on the vital signs. And so what I do is I kind of triangulate between what I see the doctors doing in clinical practice and then what happens and in clinical practice, there's all the heterogeneity of the patients, right? And then I look at what they do when I hold constant the patient's preferences, the patient's condition, and all of the vital signs tracings. And so I established this framework that led me to conclude that organizational norms, that is sort of those practice patterns that happen at the hospital level that are sort of sticky, that we notice when we go to work at a new hospital and we're like, oh, they do things differently here, that those norms essentially influence physician decision-making heuristics for seriously ill patients. And I'll try to take you through how I drew that conclusion. Norms are commonly agreed upon rules of behavior. They're often reinforced by social sanctions or formal sanctions. Heuristics are mental shortcuts that allow us to solve problems efficiently, that allow us to make judgments, but they can introduce bias. And so if you think about this from a conceptual framework, you can imagine that an organization like a hospital has for formal policies and rules and incentive structure. Those influence the individual's values, judgment, self-efficacy, and communication skill. And that those are also influenced by social norms. Those then influence each other's social norms and individual judgments, and they both go on to influence utilization, such as care processes and patient and family expectations. So I started doing this ethnographic work where I would find one high treatment intensity hospital and one low treatment intensity hospital, embed for a month, follow patients in the ICU, and take notes and interview people. And then I would take the doctors into simulation, as I just shared. And I'm just going to give you like a high-level summary of the findings from one of my 2 hospital case studies. So I took 2 hospitals in the same state and the same health system, which were presumably operating in the same policy environment, and the same insurance environment. And I found that the norms of decision-making regarding life support differed significantly between the high end-of-life treatment intensity and the low end-of-life treatment intensity center. So I'm going to walk you through each of these: time, goal, advanced directive interpretation, what dying means, harms that people are concerned about, the experience of physicians and self-efficacy, and their explicit racial bias. In the lower intensity academic medical center, ICU, whether it was ECMO, mechanical ventilation, continuous hemofiltration. It was all instituted with a time-limited trial. So the doctor would say, okay, well, we're going to give this 72 hours. And if it's not a bridge to recovery, that's the goal, then we shouldn't continue doing it. And we would know if it's a bridge to recovery because we'd expect to see some measurable physiologic improvement. So let's say some improvement in liver function or improvement in gas exchange. Whereas in the higher intensity hospital, when they started any of those life supports, it was open-ended. And as long as it could continue to achieve the goal of keeping the patient alive, it was achieving the goal. So they very seldomly linked the initiation of life support with an expected outcome or goal. When they were faced with someone with an advanced directive in hand, the lower intensity hospital had a very broad interpretation. If someone said something like, I wouldn't want to be put on a breathing machine if I were dying or, in an irreversible coma. The team would take that and say, oh, this could apply to this situation where we are right now, where the person's has multi-system organ failure. Whereas at the high intensity hospital, they read it very narrowly. They said that if they were dying or in an irreversible coma, but they're not dying or in an irreversible coma, they have multi-system organ failure. And they didn't say that in the advanced directive if I have multi-system organ failure. So we're just going to narrowly interpret it to mean they would want this. They decided at the low intensity hospital that a patient was dying, i.e., back to that interpretation of the advanced directive, if they had a terminal condition or if they had a high probability of having a very poor quality of life upon survival. And so they, again, had this kind of broad definition. Whereas at the high intensity hospital, again, because of that open-ended framework, dying was if it was physiologically futile. You could no longer keep the person alive despite maximal life support. At the low intensity hospital, the doctors were concerned about harms of commission. The thing that bugged them is if they accidentally kept a person alive against their will. Whereas the high intensity hospital, they were worried about harms of omission, failing to keep somebody alive, failing to act when it was the case. And so the two hospitals had a very different kind of experience if a patient accidentally was intubated. The DNR wasn't available in the emergency room and they were accidentally intubated, which, happens sometimes. They find the DNR order and it says, do not intubate. The low intensity hospital would be like, okay, oh goodness, we have made a big mistake. Let's undo this and do a terminal wean. Whereas the high intensity hospital would say, well, we already started the treatment, so let's just try to get the patient through this respiratory failure, and then we can make sure the DNR is, and DNI is in place once we stop this pathway. So the idea of like undoing a mistake they made would never have occurred to them. Now, you can imagine that this sort of creates different conditions of experience for physicians. At the lower intensity hospital, the physicians had a high feeling of self-efficacy. They had a high sense of internal control. They were supporting families in decision making. And one of the things that was really interesting, when they heard a family say, oh my God, don't let my mom die, they heard, of course, if your mother is dying, you're going to be sad. And so I experience your expression of grief and distress and a begging me to keep your mother alive as a natural part of the process of experiencing critical illness. And so they didn't experience that as like a demand. They just experienced it as a normal thing, and that it was their job to support the family through any decisions that would need to be made if, in fact, life-supporting treatment could not achieve the goal that they and the family had set. Whereas the physicians at the high-intensity hospital experienced any expression of, like, keep my mom alive as a demand. And they felt like their hands were tied, and they would say things like, fine, if that's what you want us to do, we can keep her alive forever. And it was like they sort of had this learned helplessness. And then what we found at the low intensity hospital is that although both hospitals treated an incredibly diverse population, the lower intensity hospital didn't make any correlations in their mind with the patient's racial or ethnic identity and their treatment preferences. They sort of they saw cultural norms as being important for families. So for example, if there was a family where it was a patriarchal culture where a wife wouldn't be allowed to make a life-sustaining treatment decision because she was a woman. They would bring the family together in ethics to try to support a decision-making process that was culturally tailored with the patient's well-being in mind and the best information they could get, including from the wife, about statements of preference from the patient, and trying to protect her from being in a position where she was like being forced to make a decision. Rather, she was providing information about what she'd heard from her husband. And then, whereas at the higher intensity hospital, there was like every single racial profile you could imagine. I heard them say, oh, Asians people, that's how they're like. Oh, Persian people, that's what they like. And I heard them over and over make these just off the cuff comments, even though as I would sort of like pay attention to what was happening in the room, I just saw a wife or a mother or a grandson doing the things that they do at the bedside, being worried about what's happening, asking questions. It had nothing to do with their racial identity. It was just that they were of that racial group and they were stressed out. And so it was just a fascinating case study of two hospitals that got me sort of thinking more and more about this. And so I said, well, what is it if you're a doctor and you arrive at hospital, one hospital versus another, how does it affect the way you think? And so I took these doctors into their simulation settings, and I'm going to try to walk you through this to sort of give you an example of what happened. Over here, what I'm going to tell you about is that on the upper part of this figure is what happens at the low intensity hospital that I just talked about, and then what happens at the high intensity hospital below. But every single doctor is given the same exact information. They're called to see a 78-year-old man with metastatic gastric cancer. That's that picture I showed you a couple of slides ago. And they're asked to evaluate his slowly progressive hypoxia and hypotension. He's got no DNR order on the chart. He has an underlying, like I've trained the actors and the wife to have an underlying preference to avoid intubation and mechanical ventilation. He's had a hospitalization recently where he had prolonged MV and he's wanting to avoid it, but he hasn't like documented anything. And so at the low intensity hospital, if they're being summoned for unstable vital signs, it means that dying is unexpected and that DNR means that the patient must be full code. And this is because at the low intensity hospital, many patients don't want intensive care. Oncologists in the outpatient setting discuss advanced care planning, and admitting hospitalists always discuss code status. So this patient could not have gotten into the ICU without having a code status discussion. And if there was therefore no DNR order or no DNI order on the chart, it means that the code status discussion was had and they must be full code. And so when the low intensity doctors would come running into the room and see the patient, they would be looking at the chart that I gave them and they'd be doing this. And I said, what are you looking for? It's like in the debrief. And they said, well, they must have had a code status conversation because we always do that, but I don't see the conversation in the chart, so I can't tell what's going on here. Give me a quick second. I'm going to plug in my computer. And so they basically were confused. But their heuristic as they went into the room is if there's no DNR order on the chart, they assume the code status has happened. So they think that the condition must be potentially that's actually a typo, potentially a reversible infection. And this sort of paradoxically, in the low intensity hospital, the doctors that were called to see this patient were more likely to initiate life support because they were thinking, well, otherwise, why would I have been called to see the patient? Whereas at the high intensity hospital, they have this experience where, the oncologists do not discuss advanced care planning, that admitting specialists do not discuss code status. And so when they came in and looked at the chart and there was no code status, they weren't surprised by that. They're like, oh yeah, the oncologists never talk about this, or the admitting doctors never talk about this. And it's always left, and they got mad, always left to us as the hospitalist or the intensivist, depending on who my subject was, to do the conversation. And so the metastatic cancer for them on the chart was salient, and it means that the patient's dying, but nobody has talked to him about it. And so they sort of assumed in their intuitive judgment that the person has an irreversible cancer, and again, is also going to be less likely to want to treat them intensively. The key here is that Doctors from the low intensity hospital saw the exact same case and assumed that the cause of decompensation was sepsis. The doctors that came from the high intensity hospital thought that the cause of the decompensation was cancer. Exact same case, because of the heuristics, the social norms around their hospital and the practices they've seen, it led them to interpret the diagnosis differently. So it's a super fascinating kind of demonstration of the ways in which organizational norms influence physicians, unconscious perceptions of what's happening physiologically. The thing that's great about this case is that in most instances, because the patient was still able to talk, they had their mask on, if the doctor had the wherewithal to ask the patient, has anyone discussed whether or not you would want to be intubated? The patient's only line was, no tube. And so the patient could avoid getting intubated as long as the doctor asked. And luckily, in both the low and high intensity hospital, they usually asked. There was sort of a very rare instance where people were basically made decisions without asking the patient. They made assumptions. So no, these norms and heuristics, I think, then shape the way that patients and surrogates talk, that doctors talk and patients and surrogates believe. So I took all of the simulated, like I audio recorded all of these interactions between the doctor and the patients. And what I found is that whenever the doctor presented, because they essentially asked, well, we're faced with a decision about whether to intubate you or to do comfort measures, but they didn't ever say we're faced with a decision. They always said they used a different modal verb, will, must, when talking about intubation. They always presented intubation as the treatment option first. They said, well, given your vitals, your oxygen, we must, we will need to intubate you. And then they'd say, or we could do comfort measures. And so they introduced intubation before comfort measures. They never presented comfort measures first. And then when they presented comfort measures, they used in this sort of like different rhetorical frame, could or ask. And so what that does is that's just like a manifestation of our own anxiety as physicians. We see those vital signs and we're like, oh my God, we have to intubate. We don't say, oh my goodness, we are faced with a choice. Right. And so our own anxiety at seeing those vital signs leads us to use language that when I interviewed the doctors afterwards, I'd say, so, tell me what you thought of this patient. And they were like, oh my God, regardless of whether they were from the high intensity or low intensity hospital, they were like, yeah, no, he's sick, he's dying. I don't want to intubate that guy. That's not a good idea. And so even though they saw the chart and saw the patient and their gut was like, oh my God, this would be a really bad idea to intubate this guy. They still found themselves using must and will language. And so this is super fascinating. Again, the things that we do and then when I would ask them about that, they would say, oh, yeah, a great example is they would sometimes, if the patient said, no tube, the doctor would say, okay, so I just want to be sure. You know that if I don't intubate you, you will die. Do you understand that? Yes, okay, so you're okay. Whereas if somebody had said yes to me, they would never say, are you sure you want to be intubated? And so there's this like concern that I saw manifested around the way that these different treatment options. And again, this is because you're meeting the patient for the first time, don't have a prior relationship, and they're really worried about making a mistake. I took the same framework of simulation and I brought it to trying to understand these racial differences to see if we could understand kind of what might be happening in race discordant encounters. And so I created the exact same simulation that I just talked about, but I basically had the patient be Black and his family member be Black, or the patient be white and his family member be white. And to see what happened when the doctors were faced with the patient. This is actually a simulation that I did in Pittsburgh. And one of the things that was super fascinating was that among the 30, it was a very small study, 33 physicians I ran through this simulation, they would either see the Black family first and then the white family, or vice versa. The cancer situation was a little bit different and the cause of the infection was a little bit different in both cases. but they were similar enough that they had the same kind of feel, which is it's an infection in the context of metastatic cancer, and if the patient does and is, essentially impending respiratory failure, and if we intubate them, they may not be able to ever, speak to their family again. They may die in the ICU. And so it's kind of a fraught decision. But I found that regardless of whether they saw the Black patient or the white patient family, they said the same things. I just told you a little bit about how we looked at their language. They introduced a treatment option. They talked about intubation first, comfort measures second. But they did something different when they were with the Black family. You can see here's an example of a patient just a photo on the left is with the white family and a photo on the right with the Black family. And you see how the doctor on the right has a closed posture. He's holding his chart in front of him and he's standing far away from the patient. Now, this isn't the same doctor, but what we found is that when the doctors were seeing the Black patients, they were less likely to look at the surrogate. They were more likely to look at the nurse. They were more likely to have a closed body posture, more likely to stand farther away from the bed for longer periods of time, and less likely to touch the patient. And the interesting thing is I had a resident do all of the coding of these videos and measure how far away the patient was and how many minutes the doctor was touching the patient. But my investigator, Deepika Mohan, and the way we were running the simulation rooms is that she was running one room and I was running the other. And then when our subject would change to the other room, we would run past each other and I would go run the other room and she would run, her doctor's room. And so we were basically going back and forth, seeing our subject see a Black patient and a white patient, or a white patient and a Black patient. And as we're like running past each other, I'm like, are you seeing this? And she's like, oh my God, it's crazy. They're not touching the Black people. It was so obvious to the naked eye that it was really disturbing. And so I did go ahead and have it all coded up, but it was very obvious. So this lack of, I call these rapport building behaviors, you can imagine that even though you're having the same verbal conversation with a family about treatment, do you want to be intubated or do comfort measures? If I come up close to you and I touch your hand and talk to you about that, you might feel like I care about you. And you might feel more comfortable and trusting to have that conversation with me. But if I'm standing sort of 2 feet away and talking about those two treatment options, you might feel differently. And so it's a pretty powerful demonstration of the ways in which implicit biases, which might lead to less comfort in a racially discordant encounter, could lead to less kind of patient-centered communication and outcomes. So with looking at the time, I'm going to wrap things up here. I do want to just share one little thing about me is that I was privileged when I came to Dartmouth to train as a palliative care physician. So I had been observing palliative care as a field growing up during this 25 years that I'm studying end-of-life decision-making. And I'm watching palliative care providers and I'm thinking, that's the way when I was an intern in general surgery, I would have loved to have taken care of patients who were at the end of life. And so when I was recruited to come to Dartmouth to be an endowed professor here, I negotiated. I said, if you'll let me be a palliative care fellow and complete an ACGME fellowship. So over 12 months of my first 18 months on faculty here, I was a palliative care fellow. This is a photo of me wearing a pair of reading glasses over my regular glasses because I couldn't see Epic because it was so small. I was a 50-year-old fellow, unable to see the medical record. Now I have progressives, and so I can do that. But this was like one of the photographs that they caught of me in the team room where I was trying to see Epic as an old lady. So with that, I will stop my sharing and thank you for listening to my little story.
Thank you, Dr. Barnarto. Absolutely fascinating, and especially to see the evolution from internship, surgical internship, to becoming an endowed professor and being a palliative care fellow at the time when it's just as amazing and inspiring. to see, and it's very truly fascinating that you're driven by the passion of actually finding answers to the questions which you had observed right from your intern year.
That's right.
That's and okay, so we'll open up for questions. While we are waiting for questions, I'll just start with a question, Dr. The low intensity and high intensity academic medical center, the difference is what you observed in practice patterns was quite fascinating to me. When I was just listening to it, it just for a moment felt like Daniel Kahneman's system one level of thinking, the fast thinking is actually completely different for physicians in the low intensity academic medical centers, the intuitive immediate response. The
Yes,
heuristics which
exactly.
you're talking is it's the fast, the system one thinking is completely different. And largely, and you think that's driven primarily by the organizational norms. And of course, you mentioned many other factors, but my question is, how do you think for a physician, let's say I'm in a high intensity academic medical center and I move to a low intensity academic medical center, physicians keep moving back and forth, the healthcare providers. Um, how would that actually translate? Would it be uh, the fast thinking or the intuitive thinking? Like most of the things what you mentioned was the same patients and physicians from two different having a different intuitive clinical intuitive response. So, in your opinion, what do you think that is driven from? Of course, you mentioned many factors, the single biggest factor which you think, and how about the physicians actually moving across the low
Yeah,
intensity and high intensity centers?
this has been, so there have been these study designs that have, they're called mover studies. They're usually done with patients moving from, for example, a low intensity
Uh-huh.
diagnostic region to a high intensity diagnostic region and showing that they accumulate diagnostic labeling because they go to the high intensity area. Um, there have been, if I recall correctly, there's probably one study, and maybe by Brenda Surovich, I'd have to pull it up, where we looked at the tendency towards being more likely to order tests and treatments on the edge. If you move from an area that has sort of like a conservative practice area and you go to a high intensity practice area that orders more tests and treatments, you tend to adopt the new treatment practice pattern of the place you go. So that's been shown in like things like ordering a EKG for pre-op assessment and certain other things that are kind of considered low value care. They're sort of an acquisition of the low value care behaviors. But no one's done a study, to my knowledge, of looking at things like decisions about whether or not to broach advanced care planning or to have to put your own patient on life support. So I
Right.
don't think that study's been done. But based on that inference from that other study, I think that people tend to sort of like shift towards the practice pattern in their new
Oh,
environment.
okay, okay. So we have multiple questions here. So first is from Esther Thatcher. She says, "Thank you so much. I love this research. I recently was on the other side needing to make a decision for my loved one. I noticed there's a huge difference between the language on a DNR form and the actual visceral and highly specific clinical conditions in the moment the family is asked to
Mm.
make or affirm a decision. Has this been studied?"
Let me just start by saying I'm sorry that you were recently in that situation. And I think that it's really, it's pretty humbling for each of us as clinicians or scientists when we're put in the position. It's all of a sudden you realize how much the decision, how little you know, and how much you sort of are relying on the experts to help guide you, and how powerless you feel. We have done some research. I haven't done research specifically to the question that you asked, but we have done some simulation looking at how doctors talk about cardiopulmonary resuscitation. We found that when we took surrogates and we randomized them to seeing a video of a physician talking to them about whether to choose a DNR order, but it was either called a do not resuscitate order or it was called allow a natural death.
Mm.
Um, the family members were more likely to pick the low intensity option when it was called allow natural death than when it was called do not resuscitate. There was also an influence of the doctor, if the doctor sort of said something about the norms, if the doctor said something like, in most of my patients, they choose X, the family member would sort of lean towards choosing the thing that in most of my patients they choose, and we randomized. It was like this factorial thing so that the actor would say whether DNR allowed natural death, what the social norm was, more people choose one versus the other, and so on. And we were able to establish that the way the doctor talks about it influences the choices that the surrogate makes, unsurprisingly, given that you're just looking for some level of guidance during an extremely stressful time.
Oh, great. Thank you. So we'll just have one final quick question, and then we can move to the direct meet and greet session. Helen Foley asked, did you observe any gender differences in the end of discussions with patients and family?
So I haven't studied that at all. We have just finished a paper looking at the frequency of advanced care planning billing in inpatient settings. So there's now an advanced care planning billing code that you can employ if you do one of these conversations and it meets the billing criteria of 16 minutes or more. And we find that women are more likely, but we don't know if that's because they're more likely to have the conversation or they're more conscientious about billing for it.
Okay.
This is just among hospitalists. But as far as like the quality of the conversation, I haven't done any research in that area.
So thank you, Dr. Barnarto, for this fantastic meetings. In the interest of time, for all the people here, you can feel free if there's any specific questions. They can have your information also, Dr. Barnardo, if it's okay with you to share for direct questions if they have anything pressing.
Please, that would be terrific.
Yeah, okay. Thank you so much, Dr. Barnardo. So we'll go to and thank you everyone for participating in this, and we'll move to the meet and greet session. Yeah.
Or Nicole, let us know when
Oh, hi,
we
Sam. I
can.
just saw your text now. Sorry.
That's good.
So
Yeah,
because I think people
that's
had
good.
lots of questions,
Yeah.
just
Yeah.
thanks, Dr. Bernardo. So we have a group of our faculty members here in this thing. So this is just a meet and greet session and certain specific questions.